Superficial reflexes. Superficial reflexes are elicited from the surface of the body, from receptors located on surfaces of the skin and mucous membranes. Corneal reflex consists of two parts, direct and indirect. Direct corneal reflex is performed by approaching the eye from the side. Lightly touch a thin whisk of cotton to the cornea. Look for blinking and tearing. Look for a similar reflex in the other eye for testing indirect corneal reflex. Abnormal corneal reflex is seen in posterior fossa disorders, multiple sclerosis, Parkinson's disease, and trigeminal nerve lesions. A weak reflex is seen in early stages of the above-mentioned disorders. The conjunctival reflex is tested like corneal reflex, with the cotton whisk touching the conjunctiva instead of the cornea. A normal response is immediate closure of the eye. Conjunctival reflex is abnormal in 5th and 7th nerve lesions and posterior fossa disorders, such as acoustic neuroma, brainstem strokes, and tumors. A weak reflex will be seen in smaller nerve lesions, early stages of inflammatory causes, edema, and smaller tumors exerting less pressure on the nerves. The posterior pharyngeal wall is touched with a cotton whisk or tongue blade to perform the pharyngeal reflex. The pharyngeal reflex has two components. Palatal reflex involves upward motion of the soft palate. Gag reflex involves retching and vomiting. It is depressed in lesions of 9th and 10th cranial nerves, such as pseudobulbar palsy, medullary infarct, and bihemispheric supranuclear infarct, and unilateral lesions, such as tumors, base of skull fractures, and carotid body tumors. Weaker reflexes are noticed in unilateral nerve damage, smaller infarcts, and early stages of edema and inflammation. A scapular reflex is the involuntary contraction of the scapular muscles when the skin over the scapula is irritated. Tap the tip of the spine of the scapula and acromion in a downward direction. Scapular reflex is exaggerated in craniovertebral or high cervical lesions and diminished in dorsal scapular nerve lesions. In weak reflexes, suspect slight nerve compression and inflammation. Abdominal reflex is used to determine level of central nervous system lesion. To elicit the abdominal reflex, stroke the skin gently, from lateral to medial aspect, on all 4 quadrants. When present, there is contraction of the abdominal muscles and movement of the umbilicus towards the stimulated side. Absent abdominal reflex can be due to 2 causes, physiological and pathological. Physiological causes include obesity, frailty, or muscle laxity after multiple pregnancies or abdominal surgery. Pathological causes include multiple sclerosis, motor neuron disease, neurogenic bladder, Brown-Séquard syndrome, and Chiari malformations. CREMASTERIC reflex is performed by stroking the skin over the inner thigh. It causes the cremasteric muscle to contract and pull up the ipsilateral testicle toward the inguinal canal. Cremasteric reflex is exaggerated in boys, leading to misdiagnosis of cryptorchidism. It is absent in spinal injury at L1 and L2 and ilioinguinal nerve injury. Absent reflex is diagnostic of testicular torsion. Plantar reflex is elicited by stroking the sole from heel towards the toe, along the outer border of the foot. Normally there is flexion of toes. Abnormal extension of toes is called Babinski's sign, which is seen in upper motor neuron lesions involving the corticospinal tract. It is a normal response in infants. Babinski's reflex is weak disorders, such as cerebral palsy, multiple sclerosis, and spinal cord tumors. To get more such high-yield medical content, don't forget to subscribe. BasidiaMED. The easiest and fastest way to take advanced clinical history.